Assalamualaikum and a very good morning to all respected speakers who are all actually my teachers. Um, I feel very humble being given this opportunity to share my presentation. So at the end of the talk, any comment and additional input is highly appreciated. Thank you, Prof. May and team for having me here. My topic is going to be on diabetic vitrectomy. Um, There are many ways to discuss this particular topic. Either we go based on the indication of surgery or we go based on the surgical steps in detail. So my presentation will be a bit of mix and match. Based on the diagnosis, the common indication remain the same for years, but the threshold to operate nowadays are much lower due to the improvement of the safety profile of the system. Hence, we are getting more better outcome and more predictable outcome. So when it comes to the important parts of the surgical steps, probably I will divide the discussion based on the issue of the common issues, which are the bleeding issues, the occurrence of pre-existing tear or iatrogenic tear, the difficult induction of posterior vitreous detachment in most of the cases, the issue of draining the subretinal fluid, whether you have to drain it completely or is it okay to leave some behind, and the issue of managing the many types of membranes. When it comes to dealing with diabetic vitrectomy, there's few things that we have to remember during the surgery. So most of the time, this patient has a long-standing diabetic situation. So most often they have a very much ischemic retina to start with. And it is not uncommon to have a chronic detached retina in a pre-existing ischemic retina. So that will expose the patient to have more prone breaks compared to non-diabetic cases. Usually they also have this very thick subretinal fluid. Now we also have to remember that, compared to those people who have vitrectomy, diabetic patients have compromised ocular blood flow, either involving the optic nerve, the retina, or the choroid. They can also have this underlying ischemic condition of the posterior pole or the macula. Now, when it comes to vitreous, it's not only about the dealing with the separation of the posterior hyaloid, but also the presence of vitreous crisis among our patients. And eventually is when there's occurrence of traction retinal detachment and combined rheumatogenic retinal detachment, it doesn't follow the Linkoff's rule. And it's not also uncommon for us having difficulty to find the tear, especially in a chronic condition. Another condition that we have to deal with is the issue of bleeding, either intraop as well as the post-operative occurrence of bleeding. So how do we start preparing the patient? So we start with our pre-operative preparation. Again, I would like to subdivide all those plans into making the correct diagnosis, preparing the patients itself or preparing the eyes, prepare the instruments, have the best instrument in hand, and also start to prepare the surgery. Now, when it comes to diagnosis of vitreous hemorrhage, again, it is not as simple as it sounds like. To me, it matters whether it is a pure or simple vitreous hemorrhage with no traction retinal detachment, whether it is a complete PVD or whether it's actually a complete laser eye or incompletely lasered eye. And what also matters is whether we are operating on an active disease or a quiescent disease eye. Now, again, when people say vitreous hemorrhage, as we know, it might not be as simple as it sounds. For example, this one is intragel bleed. We can't really see much of traction retinal detachment, so hopefully the surgery, will not be too complex, but we still have to deal with the posterior vitreous detachment, which is probably not present in this particular case. If you can see this one, it is mainly you're talking about subhyaloid hemorrhage. And we know there's a patchy area of posterior vitreous detachment. There are some areas which is not being detached. We still have to deal with a lot of this strong adherence posterior vitreous. Now look at this. Yes, there is some limited also vitreous detachment, not much of traction retinal detachment. And this one probably will tell us there's a lot more traction to deal with. So now to me, the best vitreous hemorrhage to do with are eyes with non-resolving vitreous hemorrhage in a completely detached vitreous hyaloid, as well as who actually has received a complete panretinal photocoagulation. So that is the only probably most easiest vitreous hemorrhage to deal with. But the rest, we should never underestimate our vitreous hemorrhage cases because the complexity seems to vary. But at the end of the day, we will try to minimize the complication by planning the surgery, stick to the main objectives, and try to have a smooth recovery period by securing all the bleeder point. When we prepare the patient in our setting, medical issues are still one of the major issues that we have to deal with. Now, the importance of pan-retinal photocoagulation is still very important, although we have the intravitreal anti-VEGF nowadays. There are still studies saying that preoperative PRP have slightly better outcome compared to those without the PRP. Probably in some patients that we could not wait to complete the PRP, in patients who have a combined TR-DRRD, the only eye patient, and we do not want to wait, those with both eye involvement, and also those who have a vitreous hemorrhage without any prior pan-retinal photocoagulation. So for the anti-VEGF, of course, we will give anti-VEGF 3 to 7 days preoperatively. No doubt it helps us to manage the bleeding issues intra-op much better. And also to be careful with the anticoagulant of the patient. As much as we can, we try to stop the anticoagulant, although sometimes I am quite okay to have aspirin on board. Most of the other anticoagulant, we will try to discuss with the physician whether we are able to omit the anticoagulant at least 1 to 2 weeks prior to surgery. And the option of anesthesia is also very important. Complex cases, young patients probably want to do NHGA, so we can have a very comfortable surgery both for the surgeon as well as for the patient. Having said that, we are still able to manage most of our cases under the subtenon anesthesia. Now, once we have prepared the patient, now we have to prepare the instruments that we're going to use. Of course, small gauge vitrectomy is one that we are going for at the moment, but particularly for advanced diabetic eye diseases, I will go for either 25 or 27 gauge. I don't use 23 gauge anymore, especially not for diabetic patients. But there's a bit of limitation with the 27 gauge. Despite being small, I find the shaft is still a bit, it's easily bent, especially when you do a complex surgery, especially when you have to deal with all these difficult membrane peeling in mid-peripheral region. So you sort of have to rotate the eyeball, or you need to sort of be in a bit awkward position. The 27 gauge cutter tends to bend. So for complex cases, I will still go for 25 gauge. For less complex cases, I will go for 27 gauge instrument. Another advancement in our cutting system is the bevel tip. And don't forget our valve trocar. That is still the preferred trocar. It helps to prevent the fluctuation from intraocular pressure. It prevents the turbulence inside the eye, and that at the end will help to control the issues of bleeding. Now, one important steps that we also sometimes overlook is the positioning of the ports. Typically, we will place a port at 10 o'clock and also 2 o'clock position. Occasionally, we might have to move our ports to be slightly more horizontal. So maybe at 9:30 and 2:30, especially when we have a pathology superiorly, give more PRP superiorly. So in having the horizontal position of ports will allow us to have a better access to the superior retina when we perform any kind of maneuver. And don't forget, we also have this curved endo laser, and I'm also a big fan of the illuminated laser for diabetic cases. It's the smaller the better, of course. We will go for 25 and 27. Again, just to highlight the beauty about having the bevel tip. This is a normal, our usual tip before, and now it's a bevel tip. What is the difference? It's not only the shape of the cutter, but also the placement of the opening of the port will be much closer towards the end of the tip. In other words, we will be able to do our surgery or our work, very, very close to the retina more effectively. You have an effective suction, and the smaller tip as well will allow us to be able to go underneath all the membrane to dissect the membrane safely. Now, just to share the beauty of having the tip at the end of the opening, very close to at the end of a tip, when the suction is more effective. This is a video just to show that we are trying to remove the posterior hyaloid, but because the suction is very effective, it is also removing the subhyaloid bleeding safely. Of course, we can do this when the retina is flat. Now, the beauty of this having the opening of the tip and the suction very close towards the end of the tip is sometimes if we have difficulty with our internal limiting membrane, we can actually use the cutter to suck or peel off the internal limiting membrane. So that is to show just how effective is this bevel tip cutter. Another important tool that we always use in our retinal surgery is staining. There are at least two types of common stain that we use, which are either the blue dye or the triamcinolone. In this particular case, like diabetic vitrectomy, usually we use the triamcinolone probably at the end of the surgery, mainly to look at any remaining posterior vitreous. Now, the other dye that we also use frequently is the blue dye. For example, let's say this particular case, and we can also see, this is the location of all the dye behind the subhyaloid space. So potentially there's one space here, another space there, and probably another space there. So that is where we're going to put in our cutter to induce the kind of delamination or segmentation. It also helps to stain the fibrous tissue as well as the internal limiting membrane. Just to share another important role of the triamcinolone. At this particular time, we are actually clearing out the posterior hyaloid, removing all the traction around this fibrous tissue. You can see we are cutting the AP traction of the posterior hyaloid around the tissue. Segmentation. And initially we thought that, we probably have cleaned up most of the gel, pretty quite happy. Then we decided probably we should give a try and still inject a bit of triamcinolone at the end of the surgery to make sure that we have cleared up everything. So what happened is once we injected the dye, this is when we injected the dye, and then again it helps to highlight the remaining or residual posterior vitreous, which is still attached anteriorly to the fibrous tissue. So we managed to clean up that bit completely, and patient ended up well post surgery. Now the next one would be on if let's say the retina is highly detached and we could not induce a PVD using one single hand. Sometimes we have to do this manual technique of releasing the posterior hyaloid. So one hand is actually, with the help of chandeliers, we have the chandelier on the other corner of the eye. So we will use the forceps in one hand and a cutter in the other hand. Of course, the cutter will be facing away from the retina. So this will help to gently dissect the posterior hyaloid away from the detached retina. So you can see slowly everything comes off very gently. So that is one of the way of doing it. Another way to do it is, again, also using the forceps and the cutter. How much do we have to induce all this PVD? I think it depends on how much retinal changes present. Another way to do it is instead of using forceps and cutter, this one I was using a cutter in one hand using a very gentle suction. Having a heavy liquid inside the eye helps to create another, and it gives a bit of counter traction posteriorly. So I was using a vacuum from the cutter and slowly lift up the posterior hyaloid. So it comes to membrane. Basically, we have many types of membrane. We have the preretinal membrane, and also we have the subretinal membrane. Preretinal membrane is very common, especially in TRE cases. But the moment we have subretinal membrane, probably we are dealing with the combined traction retinal detachment and the rheumatogenic retinal detachment. Using our small gauge cutter nowadays, this is what we can do effectively. With this patch of fibrous tissue, there are many ways to deal with it. It is either we use a bimanual technique with the help of a chandelier, or usually we start with segmentation of the membrane. So try to segment as much as we can. If it is difficult, it's very tight. If let's say the retina is highly detached, then we have to go for the bimanual peeling. So this is one of the example of how we do the segmentation of the membrane. We go very close. Well, this is quite close to the retina, but then we can see there's some areas of blood, so we know we are quite far. There's some kind of space there, and setting, usually we try to bring it down to. I usually bring it down slightly to about 5,000. If it starts with 10,000, probably I bring it to half, and also reduce down the vacuum. Let's say the standard vacuum is about 600, then I will bring it down to just about 100. So segmentation was done. Now again, this is sort of I would say like an unplugged kind of thing, very broad attachment. To me, it's very broad. So we try to sort of peel it off as much as we can. It seems like there is some space there. So again, we continue to do the segmentation, and at the end, usually we try to peel off the internal limiting membrane. This is another video showing one of the cases I have to remove the subretinal band. So after cleaning up the vitreous gel, initially I thought I can get away with this subretinal band. You can see a bit of star fold down there, and this one very quite a thick subretinal band. So I was this one I was doing the segmentation of the posterior hyaloid. This patient actually presented with a very wide dense cataract. So after removal of cataract, and the projection of light was quite good before the surgery. So I thought, okay, fine, let's give it a try and see how much you can see, because the projection was quite good. So what happened is, so try to clear out as much as we can. You can see the posterior is still strongly attached. You can see the retina is moving. So what I was trying to do is I was trying to segment or isolate that particular traction away. So clearing up all the posterior hyaloid around that particular focal traction area. So again, this one was trying to clear up the preretinal fibrosis. And finally, I was trying to flatten the retina and trying to assess whether I'm able to flatten this part of retina, especially because it's very close to this. There was actually an iatrogenic tear. The location is just nice, very close to the subretinal band. So I placed in some heavy liquid behind, but then I feel like, no, I was not able to flatten this particular area safely. So we remove the preretinal fibrosis as much as we can, and then go for the subretinal band. I was quite confident the position of the hole is actually quite nice and sort of allow me to assess the subretinal band safely. Subretinal band removal, the best way is always to do the bimanual technique, so we need a chandelier. So I was using the either forceps as a pulley to remove the subretinal band. So you can see once the subretinal band is removed, the retina is flapping freely. So this is always the the moment that we as a surgeon feel very happy to see, and feel more confident to close the surgery safely. Now, issue of bleeding. Now, to deal with intraoperative bleeding, the control has to start even before the surgery. So we give them anti-VEGF preoperatively. We omit all the anticoagulant safely with the help of our physician. And intraoperatively, if the bleeding still occurs, I think the common things that we do is to change the bottle height. The normal bottle height we keep at 25 to 30 millimeter mercury, but the moment we have a bit of bleeding, we might increase the bottle height. Frankly speaking, I do not like to do this. We know that this patient has already an issue with this compromised blood flow to the optic nerve. And then if I can see the bleeder, yes, of course, we go and diatomize the bleeder. We love to use heavy liquid. I like to use heavy liquid, and it stops the bleeding very effectively. And at the same time, you can continue to do your job while having the heavy liquid tamponading the bleeder at the posterior pole. And occasionally, we can also use the bimanual technique to cauterize the bleeder. So with the help of the chandelier, so one hand we will be holding the diatomy, and the other hand we probably will be holding the back flush. So so we flush the blood to look for the bleeder, and at the same time diatomize the bleeder. So just an example, if we have to use the heavy liquid, so there was actually actively bleeding in the back, you can see all this fresh blood. So what we do is place heavy liquid behind, allow the bleeder to stop, and while we are doing all the work, trimming all the posterior highlight and also the membrane around anything beyond the heavy liquid. And once everything is clotted up, then we slowly remove the blood clot. Another nice way is we can actually use our the reflux mode. Sorry, we call it the reflux mode, but I tend to see this reflux is very gentle. You can do it for a very mild kind of bleeding. Now, a very important message is never underestimate any types of diabetic vitrectomy cases. And most of the time, the amount of membrane does not really correlate with the difficulty that we are going to have during surgery. With that, thank you.